artificial intelligence and anesthesia, because the latest issue of Indian Journal of Anesthesia, I don't know how many of you had the opportunity to go through that. It was mainly on artificial intelligence use in the various various uses in anesthesia at various levels. Now, to understand artificial intelligence, can anyone, Vidya, can you just say what is artificial intelligence and why we are using it? Or Hiranmayi, or Shobhika, Sanjuta? Why artificial intelligence? Was it introduced for medicine or is it being introduced for other fields also?
First, it was introduced for other
It was introduced in other fields, then only it has come to, just like the aviation industry drill came to anesthesia or safety practice of anesthesia. Artificial intelligence also has been borrowed from other simulation techniques were actually borrowed from aviation industry. Similarly, artificial intelligence is also borrowed after it has been employed and used in other areas. Now, to understand this, can any one of you tell me, supposing you have to give anesthesia for, say, a laparotomy, okay? How will you proceed to give, evaluate this patient? How will you proceed to give anesthesia? Jobika?
For a laparotomy patient, first will go by
get the history, very good. History, then examination of the patient.
Yes, sir. History, examination of the patient, and investigations, labs.
Investigations.
And according to the patient's history and examination based on the surgery, sir. Type of surgery.
Type of surgery.
And anesthesia, drug.
So generally, you prefer to give GA or you do it under epidural? For the duration and nature of the surgery, isn't it?
Yes,
so preferably,
yes,
it will be a combined epidural with the GA will be the ideal technique because it can produce a good pain relief without the need for many opioids and other drugs. Polypharmacy can be reduced. And at the end of the surgery, you recover the patient and send them to the intensive care or the post anesthesia care unit. And ambulate them as early as possible, resume oral intake as early as possible, and discharge them when they are fit enough to go home. Right? Okay, this is the normal procedure that you do as an anesthetist. Imagine a situation, instead of you, a computer is going to do all these things. That is artificial intelligence in anesthesia. Okay? So the artificial intelligence is employed because of the availability of good computers and where we can feed lot of data. That is the data collected by our previous manual experience where we have been using the monitors, recording and jotting down in our anesthesia track record the patient's behavior, the blood pressure, the oxygen saturation, everything. All this data is fed into a computer. And then the computer is made to analyze these things. And come to, but nowadays, all of you will be aware that you have computerized ECGs, isn't it? All of you would have had a chance to see that. As soon as it takes the printout, you will find a diagnosis given by the computerized ECG machine itself. It will say there is a TV inversion lateral wall, think of ischemia. But finally, it will say clinical correlation is needed. Isn't it? And some machines will say normal ECG, abnormal ECG, better to consult. All these things are done by feeding the computer with various data which will we compare with the ECG that is taken, and that will make the machine to give a probable diagnosis. The same thing is done in artificial intelligence. Instead of you racking your brain, you give all the data to the computer and then feed the patient's present complaints, his biometrics, everything, and that will decide right from preoperative evaluation to advocating a pre-medication, then the plan of anesthesia, what are all the investigations needed, evaluation or studying of all the investigations, and then planning the type of anesthesia, and then monitoring and trying to do the problem solving intraoperatively. If there is a hypotension, what to do? If there is a hypertension, what to do? Or if there is a inadequate anesthetic plane based on the BIS. So like that, everything is taken care of, and the machine itself adjusts all these things. And that is possible because earlier there was open loop systems in all the medical equipment that we were using. What is the difference between open loop and closed loop systems? This is another terminology which you have to know if you have to understand artificial intelligence. What is open loop system and what is closed loop system? Have you heard of this?
No, sir. No, sir.
Breathe. No, sir.
Open loop, you have to do the adjustment. For example, earlier days when we were postgraduates, if you put a patient on ventilator in the ICU, we will first select the tidal volume, respiratory rate, IE ratio, oxygen inhaled or FiO2, everything will be decided. Patient is intubated and connected to the ventilator. And at the time of intubation, patient is totally apneic, not breathing at all. And whatever settings you have kept, patient will be comfortably tolerating. But after say 2 hours or 3 hours, when the patient starts regaining consciousness, starts getting respiratory attempts, and he also tries to breathe on his own, then the airway pressure will go up and patient will struggle with the ventilator. So at the time, the high pressure alarms will go on, and you have to identify that problem and reset the ventilator in a suitable way by reducing the tidal volume or reducing the respiratory rate or introducing SIMB or pressure support method. Like that, all you have to manually do all these adjustments to suit the ventilation for the patient. This is called open loop system. That is, you institute a particular parameter initially, and then depending upon the patient's response, you further modify the parameters manually. This was called the open loop system. Similarly, in anesthesia theater also, what do? You induce the patient, you give a narcotic, you intubate the patient, surgeon starts, and during the skin incision itself, pain relief is inadequate, there is a tachycardia, hypertension. Immediately, your senior tells you, give some more fentanyl, deepen the plane of anesthesia, increase CO concentration, isn't it? So you are doing all these things manually. Imagine a situation, instead of you doing all these things, as soon as these changes occur in the patient, if the machine itself is able to recognize this and then alter the parameters or the delivery systems accordingly, this is called closed loop system. Okay, so it makes you more lazy. Instead of breaking your head, machine itself will be able to do all these things. But at the same time, it makes it more safe for the patient. Because as a person, if you are doing a long list and you become quite tired after the third case, if you start after 3:30 in the afternoon, from morning 6 a.m. you are in the OT, your concentration is likely to get little lost, and you may feel little tired, and you may be missing a few points. All these things is possible. So in order to avoid all this physical strain on the anesthesia personnel or the medical personnel, nowadays we are gradually going into introduction of this artificial intelligence system, where the system will be able to recognize all the problems just as you are doing it manually and take immediate corrective steps to ensure that the patient is interior milieu is kept in the normal range, and that offers a more safe anesthesia for the patient. So it has been introduced not only for intraoperative management, but right from the uh, preoperative state itself and up to the postoperative uh, care where you have to take care of the patient. So I'll just show you a presentation which will help you to understand as well as write the answers for this question in your theory paper as well as your are you able to see my slide screen?
Yes, sir.
Yes.
Yes.
So artificial intelligence and anesthesia. This is the common question that is asked. So AI is defined as a broad concept of machines designed to understand and perform tasks on their own in a smart manner. So the computer becomes a smart equipment, just like your smartphone. The computers are becoming smart equipments. It can be thought of as programming of computers to simulate the cognitive functions of the human being. That what you are thinking and what you are doing is all programmed into the computer to simulate your own normal cognitive action, pattern recognition, and problem solving. So whatever you can do, in case intraoperatively there is a hypotension after spinal, what will you do? You are giving spinal for a
Can rush the
so,
fluids, give
rush the
vasopressors.
fluids or give vasopressors if it did. Okay, if it is if the machine itself is able to do all these things, that is called artificial intelligence. Okay, so pattern recognition and problem solving. So one of the simpler ways in which a computer can be used in anesthesia is to design a servo system. It was initially done by using this bispectral index to assess the depth of anesthesia and adjust the IV agents that were going in. So TIVA or TCA is the oldest AI introduction in anesthesia. So when you do a surgery using total intravenous anesthesia or target controlled infusion anesthesia as a main maintenance technique, instead of you adjusting the infusion pump dose or the rate of infusion or the infusion syringe dose, if the machine itself understands, if the this value goes up, it knows if the patient is becoming light, then it will immediately give a bolus dose of propofol or rush another, increase the infusion dose and then see that the BIS value comes down to 45. This is possible because of this closed loop. It is able to recognize the reactions of the patient, get the feedback from the patient and alter the administration of anesthesia accordingly. So this is the method by which that's done. And there are some subsets or branches of AI which is called machine learning, neural network, deep learning, robotics, and computer vision. These are all the 5 subsets which you are knowing. Now, what is this machine learning? That means the computer has to first learn how to give anesthesia. So in the machine learning, it involves collection and analysis of data by the computer and focus on a model development and pattern detection and make intelligent predictions. So, for example, if the patient's blood pressure and heart rate go up intraoperatively after the skin incision, if you are doing it manually, what will you think of?
Incision dice.
It is a
Relief and
inadequate pain relief. Patient is feeling the pain. That is why his blood pressure is high and heart rate is going up. He is reacting, even though he is totally unconscious, he is reacting to the pain. So the same thing, the humans are overwhelmed by, if you have too many voluminous complex data, our brain cannot assimilate all that. We are not the Asterias, Ashtavadanis or Dasavadanis where we can do multiple tasks at a single time. Whereas the computer can do all these things. So machine learning models have the intrinsic capacity to provide valuable insights based on extensive analysis and computation. So broadly classifying machine learning into three categories: supervised category, unsupervised category, and reinforcement learning, which is useful to understand the applications of machine learning. So machine learning is basically nothing but collection and analysis of data by the computer. So computer is receiving all the data, it is analyzing, and it is forming its own pattern to identify a crisis as well as the treatment or solution for the crisis. So that is what the machine is learning. So that is why this term machine learning is being used. And here it is classified as supervised learning, unsupervised learning, or reinforcement learning. So if the pattern recognition is unsupervised, supervised applications include training and testing data sets, and reinforced learning relies on continuous feedback for algorithm modification. So there is a flow chart or algorithm mostly that will be there. If this is the change, do this. If this is the change, do this. If this is happening, don't do this. That is called the algorithm. What all of you would be very familiar with that. When you say you start with a particular point, then you say yes or no, yes or no. If yes, you go to this. If no, you go to this. Like that, the flow chart will be made by the computer itself, and that will try to identify and give you the problem that you are facing. So the ultimate goal of AI-based system is to give the computer access to real-time patient data and as well as information from medical publications. So these are all the things which have been already fed into the computer, and the system would integrate the various types of data and learn the various relationships producing actionable information. So this is what the computer is learning. So that is instead of machine learning, you can remember it is a computer which is learning from the data that you are feeding into the computer and trying to formulate its own algorithm or its own flow chart and try to set a pattern where you can deal with any situation, whether it is a light pain of anesthesia, whether it is hypotension, whether it is hypertension, hypoxemia, whatever change is happening, for everything there is an answer within the computer, and it will immediately act according to that. So it is important to combine accuracy with explanations in healthcare settings, and even more so, understanding the mechanisms is critical, and consequences of incorrect prediction can be very, very dangerous. So computers are said to become indispensable tools not only for delivery of anesthesia, but also for day-to-day clinical care and decision making in anesthesia, which you will see shortly. Then the next thing is there are robots in anesthesia. Any idea how to classify these robots in anesthesia? Your TIVA or TCI pump, that itself is like a robo only, isn't it? You just like the movie Endran, you give the program and leave that. Chitty will do everything, isn't it? In that movie, like that, a robo is any mechanical system capable of interacting with the environment according to directed interventions. That is what a robo is. And robots are designed to support clinicians by automating tasks, offer pertinent recommendations based on the clinical scenario to aid decision making. And it can be classified as pharmacological robots and mechanical robots. And the target control infusion system can be considered as the first generation open loop pharmacological robot. Because in target control infusion, first earlier when it was started, you have to adjust. You first feed all the data, the biometrics of the patient, his height, weight, his BMI, his pre-medication, the drug that you are using, the pharmacokinetics, pharmacodynamics, everything is fed into that, and it decides what is the dose to be given. And then if there is an emergency in between, you have to give a bolus press and give a little bit extra dose. Also, it was a little open loop method. But later, when the feedback was available from the patient in the form of this monitoring or other depth of anesthesia monitoring, software was built in pharmacokinetic models of different drugs, and they are delivering doses to achieve specific plasma levels to maintain a steady state. And then the display estimated, even though it is not exact of the effect site concentration, based on the anthropometric measures with patient different racial characteristics, they could now modify it in such a way that it will take care of the dosage that has to be infused into the patient. In closed loop system, as I told you again, a goal for measured variables is set by the operator, and the drug delivery is adjusted to make the gap between said goal and actual variable. So we do not know which patient is going to behave in which way. So we feed a general data and set the infusion rate. For example, you give an induction dose of 2 milligram of propofol that is delivered by the machine. After that, you set it as 0.2 milligram per kg per hour as an induction maintenance dose. But in some patients, this may not be adequate, and the depth of anesthesia may be inadequate, and the BS value may go up. In that situation, immediately the machine itself will recognize that and increase the infusion rate from 0.2 to 0.4 milligram instead of you trying to alter this. So because of the variables that are available as a feedback in the closed loop system, the machine itself will be able to do that. So in the newer versions, refinements in the algorithms such as reinforcement learning and neural network will help to minimize fluctuation from the set target that you have kept. And the initial models, there are single input and single output systems. That is, you were earlier measuring only the depth of anesthesia using BSI. That means it is a single input according to which output is given by the computer. But when you want to measure not only the depth of anesthesia, you want to measure the hemodynamic stability, you want to measure the oxygenation, you want to measure the temperature, then you give what is called multiple inputs, and it will be able to react accordingly with multiple output also. So hypnosis, analgesia, muscle relaxation, everything can be taken into account, and you can make the required adjustments. So anesthesia parameters targeted by system initially included only hypnosis or muscle relaxation using the nerve stimulator and feedback for the drug delivery. Subsequently, analgo score was described for measuring pain during general anesthesia, calculated from the deviation of patient's target values of heart rate and mean arterial pressure. This is what I told you. If the patient's heart rate and blood pressure goes up after skin incision, you know patient is suffering from pain. So analgesia score, that's called analgo score, was utilized in addition to the BIS monitor, and adjustments were made. So in automated anesthesia delivery was combined with closed loop fluid management also, ultimately in the multi-input, multi-output system, where two independent closed loop systems were used for hypnosis, analgesia, fluid management during major vascular surgery. So from one single parameter, we now combine multiple parameters to put in multiple inputs and get multiple outputs. So investigators are looking for the feasibility of combining fluid administration along with appropriate vasopressor also. So initially you said you will rush fluids after a spinal, and if you not responding, you give a vasopressor. Even that is decided by the computer, and then it is put into use. So these are all pharmacological robots which were dealing with drugs to maintain hypnosis, analgesia, muscle relaxation. But the robo use is not stopping with that. It is coming to mechanical robots. Where do you think mechanical robots will be useful?
Cardiopulmonary resuscitation.
Anesthesia. This is not emergency. This is for anesthesia.
Intubation.
Intubation, sir.
Intubation and regional techniques. Okay, these are the two areas where you require good precision and experience. So instead of your trying to locate the nerve plexus and put the drug, and then if you don't put it correctly, it may end up in a failed spinal or a failed block. So in order to avoid all that, they have now produced mechanical robots, sorry, designed to include cognitive as well as dexterity based, because when you want to give a block, your hand should be very steady. You should not have any tremors or fierce tension or nervousness, and your needle may not injure a vessel or anything. It should be properly guided. So for regional and intubation, they have included this. So the Da Vinci and Kepler intubation systems came into vogue with a single robotic arm. And for regional anesthesia, there is a system called Magellan system, which with a block needle ultrasound guidance also is there. Now there is a third thing called clinical decision support system, which is also part of the artificial intelligence. So what does it know? It's a knowledge-based built-in algorithms, or alternatively non-knowledge based also. The preoperative cognitive robots are used for detection of abnormal laboratory findings. That you can feed all the investigation reports into that, and it will pick up. Nowadays, if you see many of the labs which are giving a master health checkup report, they will highlight values which are very high as H, or values which are low as L, or give a different color, so that you don't have to waste time looking at each and every value. You can just pick up all the abnormal values and then try to advise the patient accordingly. So even in the printed format, now they are using that. So if you feed the same data into the computer, it will be able to easily pick out all the abnormal findings and then ensure the correction that is needed. And this is for preoperative cognitive robo. Intraoperative robots have been used to accurately identify appropriate prophylactic and recommended treatments, dosing schedule, and give alarms, smart alarms, and efficient gas delivery, and also at the end of it, billing, theater expenditure billing. You know, every hospital, especially corporate hospital, if you see a patient after treatment, they will give split up of every item that they have used. They will say this much of disposable used in the theater, these are the drugs that were used, there's so many IV fluid bottles used, so many disposable syringes, so many gloves used. So everything is accounted. So the billing system also is included in that. And CDSS can integrate various physiological data with preoperative data to produce guidance which may be accepted or rejected by the anesthesiologist. So you don't take everything that is given by the computer as correct. You have to use your discretion also in trying to accept or reject them. Now, what is the current trends involving artificial anesthesia and artificial intelligence in anesthesia? So some AI-based advances are not reached clinical use yet, but hold promise for future implementation. That is, will be used in pre-anesthetic evaluation. It will be used in intraoperative anesthesia care, and it will be used in post-operative care also. These are all on the trends. But is there any ethical issues involved in artificial intelligence? The ethical issues are the future of AI medicine relies heavily on whatever patient data we are going to provide with that to the computer. So if the computer cannot generate its own data, so we have to provide all the data, which means we have to share some of the patient's privacy. There may be little intrusion into the patient's privacy, and without upsetting that, we must try to give all the data into the computer. So other problems that are going to happen, there may be a bias and discrimination. There will be privacy and security problem. Accountability and transparency may be affected. Models explainability, the ability, machine learning models to provide clear and interpretable explanations are little difficult. And access to healthcare. That may cause a little bit of expensive technology may be used, so it may be more costlier. And regulatory processes are needed. Government and other stakeholders must give clear guidelines as to whether ethical issues are involved or not. And biorepositories, ethical guidelines and protocols, as well as uniform methodologies have to be required. And ethicists involvement. It should be involved in AI projects for the beginner. So these are all some of the issues that may be hampering the very liberal use of artificial intelligence. Until these issues are solved, we may not be able to use that. And this picture tells you how a closed loop anesthesia system is helping. See, it is monitoring the vital signs, it is monitoring the medications, it is monitoring the depth of anesthesia by brain monitoring. Then, based on that, clinical decision support, risk assessment tools, clinical guidelines, patient data are all used. And then this can, the tailored anesthesia delivery is given based on these things. And these mechanical robots are also used for intubation and regional anesthesia. And you can even do tele-anesthesia. That is, one anesthetist may be able to monitor patients in 3-4 OTs at the same time. With the telemetry system which is available, you can monitor all the patients and reduce the need for employment of too many people. And the applications in this particular slide, you will be able to see all these things. Pre-surgical evaluation, that can be pre-operative management and planning can be done by the AI system. If you feed all the data, you feed, say, if the BMI is less than this, you give this category ASA 1 category. If the BMI is more than this, you give ASA 2, ASA 3. Like that, you can, every parameter can be fed into the machine, and that will make the pre-surgical evaluation. Then anesthetic dosage optimization. Algorithms can be set for that. And preventing drug errors. This is a very important and very useful AI-induced facility. Then early detection of complications. So machine will be always alert, and it will sometimes give false alarm also, but it doesn't matter as long as you are able to detect all the faults that are happening. That is more safer for the patient. The fourth thing is predicting patient outcomes. Machine learning algorithms can be used to predict likelihood of complications or adverse outcomes. And predicting post-surgical ICU admissions, that also can be predicted. Automated monitoring, so relieves you of the tiresome of looking at the monitor all the time. Automated anesthesia dosing, just like your TIVA and PCA. Pain management, analgesia dosage. Real-time decision support, that also can be done in case of crisis. Post-operative monitoring, that also can be included. Resource allocation. Algorithms help to optimize anesthesia resources. You can make the expenditure come down by using proper required doses of volatile anesthetic agents or induction agents. So wastage will be reduced. And it can be used for training and education. Simulate scenarios and train anesthesiologists to handle challenging situations. And image recognition. They can analyze medical images to identify anatomical structures and guide placement of regional techniques. And research and analysis. Lastly, it can be used as a permanent anesthesia record. And because these records are stored there, you can put questions into that and produce a paper. So you say patients with previous myocardial infarction of the 6 months duration coming for laparotomy. You just feed that question into that. The machine will immediately give you all the details, how many patients were operated, what happened, intraoperative behavior, hemodynamic stability, post-op requirement of ICU support or immediate restenting, everything you will get. So you will be able to produce a lot of research material or publications using all the data. So that way also artificial intelligence is going to be a very great boon to all of us. And so that is the answer that you can write for artificial intelligence. I hope